Hello, Parm Eftekari here with the Health Tech Council. I'm joined with John Showalter, CMIO from the University of Mississippi Medical Center. Good to have you.
Thank you very much.
And John, we heard you speak earlier at this Health Tech Council meeting about risk and operational risk and what you're doing at your organization. So I thought you could share with the audience, first of all, what do you think the biggest risks are that hospitals and other healthcare organizations are facing today as we start to modernize and transform ourselves through technology?
I think there's a lot of permutations and details behind that risk, but the main risk still comes down to the people and people's behaviors, whether it's malicious or just ignorant. The actions of the individuals in the organization are by far the highest risk for security breaches and privacy protections.
Sure. It always comes down to people. So what role, I remember you mentioning some comments about the role that governance and policy can play in mitigating that risk. You're never going to get rid of the people problem. So how can you use governance or policy or other mechanisms and tools to kind of start to mitigate that?
So I think governance, and by governance I mean the committees and the decision-making process in order to help protect the institution from any breach or negligence. But also, you can't educate your people if you don't make decisions on what they're supposed to do and how they're supposed to do it.
Mm-hmm.
So we have a very robust governance structure at the University of Mississippi. It's actually a three-tiered structure that starts with the end users, and we have committees for nurses and inpatient, outpatient, and physicians where proper behavior in the electronic health record or with PHI are decided. Policies are written, they're taken up to a director-manager level, and disputes between the committees are settled at that level, and ultimately they're signed off from the executive committee that has our chief quality officer, our CFO, our CMO.
Oh, great.
And we end up with full institutional policies that we can then build the EMR to those policies as well as train to the policies. And if we run into any risk situations, we can go and tell CMS that we educated them, we signed off on their education, we know what they're supposed to do, and they were behaving outside of our policies.
Absolutely.
Which still does not help protect the patient from their loss of data, but does help protect the institution.
Absolutely. So it sounds like you've had success in getting organizational buy-in in terms of senior leadership and management understanding the importance of this and putting their voice and their clout behind what you're doing.
We have, and I think one of the keys to that success is the way that we've organized the groups are that groups that have trained similarly, so therapists and nurses train very differently than physicians. We put them in separate councils so that they can come to a single decision. If they don't come to the same conclusion, we do then have a council that sits above them, that settles disputes and settles disagreements. But it allows for faster decision making because the different perspectives don't clash.
Fantastic. And we talked a little bit about buy-in just now. Now, what about from the employee perspective? What are you doing to incentivize them to pay attention during their training and follow these guidelines? Because we all know that change is disruptive. Nobody likes to be told how to do things, and we're already seeing a lot of resistance when it comes to implementing technology. So how are you also overcoming that while also adding on another kind of requirement, which is security training and adherence to those policies?
So that's actually been a big struggle. And we're still trying to feel our way through that because we've added electronic health record education training to our orientation, so we've added 8 to 12 hours of that in addition to our standards.
Wow.
Our policy education security, we're beginning to work into that as well and trying to get it embedded in some of the EHR training since it's so related. But we haven't quite gotten there yet, and we're trying to find the hours in orientation to get it.
Yep.
So a lot of it's being done through our typical compliance training, which is pretty good, but it's annual. So if you're hired the month after our training, you get it during the orientation in a very blitzed manner, and then you don't get reviewed for a year. So it's definitely an area that we need to improve.
Right.
And I think we need to work on distilling down some of the major functionalities and just saying, this is what you need to understand out of the gate and you need to learn more over the next year or so.
Yep.
And we've had some really good conversations about it at this meeting, actually, some of the best practices from other institutions and discussions about, should you train all of your end users the same if you have a highly social media using group? should you treat them the same way as a group?
Different age differences, I know we talked about as well.
Yeah, so I think that's one of the benefits of this council is I've had more in-depth conversations about these issues in the last 2 days with very knowledgeable individuals than I probably have in the last year or 18 months, and I've been to 4 or 5 other conferences in that time.
Fantastic, great. Well, John, thanks so much for your time. We're happy to have you as a council member and look forward to your continued involvement.
All right, I appreciate being here.